CHIVA is the result of the combination of technological innovation and scientific progress regarding the hemodynamic aspects of the venous pathophysiology. It has been improved by outstanding collaborators. As a young angiologist, I was upset by too many patients not eligible for a vital venous arterial bypass because of previous saphenous ablation. Avoid amputation, save life. CHIVA is born from my will to treat the varicose veins while preserving the saphenous vein as a potential arterial bypass. This challenge contrasted with a century of ablative dogma. The literature on academic pathophysiology did not provide me with the key concepts to achieve this goal. Thanks to my earlier work on vascular Doppler, I was able to gain a better understanding of venous hemodynamics, which had been overlooked in the literature. This enabled me to propose new concepts in venous pathophysiology, which led to CHIVA. CHIVA is a French acronym for Conservatrice et hémodynamique de l'insuffisance veineuse en ambulatoire. Venous hemodynamics progresses. Venous circulation was discovered by William Harvey, but he was, as usually, challenged by all the great physicians of the time, Rayland and others. CHIVA precursors had a hemodynamic approach from Ambroise Paré to George Clemens Pertus. This hemodynamic approach was then replaced by drastic destructive methods for 90 years until 1988, when the new conservative and hemodynamic CHIVA method was proposed. Destructive methods, hemodynamics methods. A mix of echo-Doppler skills, hemodynamics study, and large clinical experience made me understand better the venous pathophysiology, which made me revise the classical concepts and propose new ones. These new concepts are based on the central role of the transmural pressure in the venous function of drainage and cardiac filling, and the hemodynamic process that regulates it. The central concept is that the etiology, signs and/or symptoms of venous insufficiency are always due to an excess of transmural pressure, whatever transmural pressure, edema, varicose vein, dystrophic damages. Transmural pressure is the pressure difference between intra and extravenous pressure. Intravenous pressure is the sum of hydrostatic gravitational pressure and residual pressure. The extravenous pressure is the sum of tissue pressure and atmospheric pressure. The venous system is made of pumps, heart, thoracoabdominal pump and valvomuscular pump, and conduits, veins, that regulate the transmural pressure values necessary to achieve the venous functions of tissue drainage, heart filling, and thermoregulation. Therefore, the treatment of the venous insufficiency consists in reducing the transmural pressure. To achieve this goal, I have proposed a diagram of the venous system to explain anatomy and hemodynamic function and to provide a theoretical, practical basis for rationally assessing and treating the venous insufficiency. I defined the four compartments of the venous network: R1, R3, R2, R4, which means réseau in French, and N1, N2, N3, N4 in English. At the same time, I defined the concept of venous shunt type 1, type 2, type 3, type 4, and the consequence CHIVA, blood column fraction, shunt disconnection, veins conservation. So the hemodynamic treatment consisted of decrease intravenous pressure by CHIVA, fraction of the hydrostatic gravitational pressure, disconnection of the shunts, normalization of the residual pressure by respecting the draining vein, saving the great saphenous vein, and or increase the extravenous pressure by compression. Combination of hemodynamics better understanding as science progress plus echo-Doppler innovation as technological progress led to CHIVA. Venous ultrasound progresses. I published in 1977 my findings regarding the Doppler semiology of vascular disease in the first book of Doppler vascular semiology. In 1981, I patented the device that made possible for the first time the echo-imaging of the deep and superficial veins and arteries. This is the first image published, and which resulted in 1986 in the first book of echo ultrasound vascular imaging, and progress in venous hemodynamics that led to CHIVA in 1988. Many other books were published later from various countries: Germany, Italy, Spain, and my last book in 2022 in 4 languages. You can download it for free from my site angio.info. Angio.info, easy to download. CHIVA echo-Doppler assessment and mapping consists of finding the type of shunts and specific strategy and technique of disconnection under local anesthesia tailored for each patient. The escape points to be checked are the saphenofemoral junction, the saphenopopliteal junction, pelvic leak points, numerous perforators, and the network to be assessed are N1, N2, N3, and 4 according to their topography and hemodynamic function. Thanks to echo-Doppler, I could describe anatomically and hemodynamically the so far not defined pelvic leak points: perineal point, obturator point, inguinal point, clitoridian point, inferior point, superior gluteal point. These scientific contributions through echo Doppler and venous pathophysiology place the author among the 50 key figures of the Vascular Origins book. This is an example of CHIVA from before the operation, at the end of the operation, no more visible varicose vein. They say this was the cartography or the mapping before the operation, and this is the strategy of the disconnection of escape points. Ablation obey the simplistic checkers rules, and CHIVA the complex chess rules. The vein preservation is based on CHIVA hemodynamic concepts that explain why any varicose vein is a victim of the flow pressure overloads, not the cause of venous insufficiency. CHIVA cures it by normalizing the flow pressure overloads. Ablation throws the baby with the bath water because not only it destroys a potential vital arterial bypass, but it is anti-physiological. Before vein ablation, patients should be informed that they are losing their potential autologous vital bypass for eventual threatening arterial disease. Bioprotect in France collects stripped venous veins and sells them to homologous bypass. Contrary to the legally informed consent, this information is most of the time not given to the patient. All the studies, trials, and RCTs validated CHIVA as better than ablative procedures, surgical or endovenous. 107 articles and 9 books published on CHIVA treatment up to now. All RCTs are favorable to CHIVA. 1, 2, 3, 4 of them. For the last Cochrane review, CHIVA may make little or no difference to recurrence and side effects compared to endovenous and laser therapy, low certainty evidence. But the great saphenous vein preservation for potential vital bypass as an advantage is not considered, despite last 2024 guidelines that confirm the importance of autologous great saphenous vein as bypass. Here it is. For the last network meta-analysis, long-term efficacy of different procedures for treatment of varicose veins, CHIVA is rated best treatment for superficial venous insufficiency. CHIVA is here, and here all the other methods. All this has been possible thanks to the support and guidance of my pupils and collaborators over the world for the past 30 years. The CHIVA adventure began in Précy-Soutil, France in 1988, followed by CHIVA expert international meetings every 2 years in 8 countries: France, Italy, Germany, Portugal, Spain, Argentina, Morocco, China. The learning curve is steep, but the result is worth it.